Yes, this is what's ruining it. It's totally what's ruining it. Welcome to a very special episode of Books in 140 Seconds, the Giller edition. Today we're talking about Light Lifting by Alexander McLeod. Ooh. It's a short story collection by Alistair McLeod's son, but let's ignore that fact. And the stories are unrelated. He talks about a group of runners, and he talks about a person delivering medication on his bicycle. But at the end of the day, his voice is very distinct and coherent throughout the book, and that is what makes this book shine, I think. What do you think, Jen?
I really did enjoy the collection, and what I thought was quite masterful for someone whose debut collection it is his ability to really alter his prose to suit the story. So you look at the first story, which is one probably my favorite story about the runners, and then you have this long, lean, striding prose, which is incredibly beautiful. And then you go to the next story, which is all about parental anxiety and head lice, and you have these short clip sentences of someone who is really just trying to keep their head above water. And he writes from the perspective of men and women, kids and people in adulthood. So really, he shows a lot of range.
Yeah, McLeod is absolutely a master of the written word. He's very playful, but it's also really raw, gritty, and angry. But you can tell he's having a lot of fun adapting what he's saying to the scenes he's setting, and I just appreciated that. As a collection whole, I mean, it was consistent. You can tell that he wrote every single story and they belong together. But some highlights for me with Miracle Mile, the very first story. Mm-hmm. So that was a bit of a letdown because I was like, oh, this is amazing. Then it sort of peters off, and I really didn't get the parenting story. But it picks back up towards the end. And as a whole, it's a solid, stunning short story collection that I think every Canadian should read.
What bothered me is the tendency to rely on these big bang out of nowhere endings, which happened probably about 3 times, and I thought was kind of almost a cheap device. I hate to say it, but you have this wonderful story about runners, and that kind of sudden graphic twist of an ending wasn't necessary.
No,
and that happens several times.
It does.
With the swimmers and like.
I got the impression he just doesn't know how to end them, so he pulls an ending out of nowhere in order to just have it to be over, which is frustrating, but I mean, it's his first collection, so we'll see where he goes from there.
And Gillernod, first time out of the gate.
Good stuff.
Not bad at all.
The heart is a marvelous pump, a tireless servant that performs its job day after day and year after year. But like any complex machine, parts can wear out and things go wrong. In some people, the electrical system of the heart begins to malfunction long before the mechanical parts show wear. Fortunately, electrical cardiac problems can often be corrected, restoring and prolonging life. This program discusses some of the new technology used to treat malfunction of the cardiac electrical system. It also demonstrates the role of the nurse in preparing and monitoring the patient and the equipment during pacing procedures. It assumes that the viewer has a basic understanding of the cardiac conduction system and EKG analysis. The first device we will look at is the temporary external pacemaker, sometimes called a transcutaneous or non-invasive pacemaker. This life-saving device was first devised in the 1950s, but didn't become practical and reliable until the 1990s. It is now standard equipment for paramedic rigs, emergency departments, operating rooms, and critical care units. Although it was originally developed to treat bradyarrhythmias, the indications for temporary external pacing have been expanded to include rapid heart rates or tachyarrhythmias. Some temporary external pacemakers can also function as defibrillators, delivering high bursts of energy through the same patches that deliver the pacing energy. It provides rapid initial support until the cardiac condition resolves or until a more reliable form of pacing can be initiated. Let's look at a typical patient that needs an external pacemaker. Mr. Atherton's father died of a heart attack at the age of 45. In spite of this known and unavoidable risk factor, Mr. Atherton has smoked a pack of cigarettes a day, lived a sedentary life, and gained 20 unneeded pounds. As his weight went up, so did his blood pressure. He didn't feel any symptoms from his hypertension, so he ignored it, until he had a heart attack. Initially, the nagging ache in his left arm felt more like a pulled muscle than anything else, so he ignored that too. He did not seek medical treatment until 3 days later, when he felt fatigued and dizzy. The triage nurse took him right into the emergency department.
Mr. Atherton, my name is Celeste. I'm going to be your nurse today. I need you to get into a gown. The opening goes to the back.
The nurse connects Mr. Atherton to the cardiac monitor using a standard 3-lead configuration. She also gives him oxygen by nasal cannula.
Hi, Celeste.
Hi, Dr. Reynolds. Dr. Reynolds, this is Mr. Atherton.
Hello, Mr. Atherton.
Hi, Doc.
Okay. What's the problem?
I'm having a lot of chest pain. I'm dizzy.
How long has this been going on?
Since last night.
Okay, and you're just seeking medical attention now?
Yeah.
Okay.
Dr. Reynolds, I need you to take a look at this EKG.
The EKG shows a Mobitz type 2 block. The atrial rate is 80, but the ventricular rate is only 40.
How's his blood pressure?
It's only 80/55. He's cool and clammy, and he's been telling me that he feels dizzy. Would you like me to get the atropine out?
Atropine may not work with this high degree of AV block, and it might make matters worse. Is a temporary pacemaker available?
Yes, it is.
Okay, insert a saline lock, and then start to hook him up to the external pacemaker.
Okay.
Okay, Mr. Atherton, we are concerned about your low heart rate. We're calling a cardiologist, but it's going to take him a little while to get here. In the meanwhile, we're going to give you your heart some support by giving it some electrical help. Now, rhythm like yours can be very dangerous, so we're in a bit of a hurry. However, I'll explain things as we go along. You can ask questions at any time. Okay?
The temporary external pacemaker is an emergency intervention for patients with hemodynamically unstable bradyarrhythmias. That is, patients whose slow heart rates do not generate sufficient blood pressure. The temporary external pacemaker has several advantages over the temporary transvenous pacemaker. Non-invasive cardiac pacing is widely available, requires minimal training to set up and use, can be performed by a nurse or paramedic, carries a small risk of serious complications, and is inexpensive.
So you agree to temporary external pacing?
Yeah. Okay.
The temporary external pacemaker consists of 5 components: pacing electrodes, a pacer connecting cable, EKG electrodes, an EKG connecting cable, and a combination pacing generator cardiac monitor. The pacer analyzes the patient's rhythm and delivers electricity as needed. The pacer must receive clear EKG input in order to operate properly. With an adequate waveform, the monitor will sense and mark each of the patient's own beats.
Mr. Atherton, I have to apply 2 more electrodes to your chest. One's going to go in the front, and one's going to go to the back.
Because Mr. Atherton is relatively stable, the nurse can take the time to place the patches in the most effective configuration, which is anterior and posterior. The anterior electrode goes on the front of the chest, to the left of the sternum, and just below the nipple line. The other one goes on the back, just below the scapula and to the left of the spine. The pacing electrode should not touch any of the EKG electrodes. Connect the cables to the pacing electrodes. The wires are usually color-coded: red for posterior positive electrode and black for the anterior negative electrode.
How you doing, Celeste? Are we ready to start pacing?
Yes, we're ready to go, except Mr. Atherton hasn't had any sedation yet. Mr. Atherton, are you allergic to any medications that you're aware of?
No, I don't think so.
Okay, let's start small with a milligram of midazolam IV push, but let's have morphine sulfate available too.
Okay, no problem.
And Mr. Atherton, this procedure can sometimes be uncomfortable. So you let us know how you're feeling, okay?
Yeah.
That's going to help you feel better.
Okay, Mr. Atherton, we're ready to start pacing now. We're going to increase the flow of electricity gradually until we can see that it's enough to trigger a heartbeat. Is the monitor set?
The monitor's ready to go.
Okay, start turning up the milliamps on the pacer. Begin at 30 milliamps and go upward in increments of 5 until we see capture on the EKG.
Ouch! What was that?
Okay, sorry, Mr. Atherton. I know this doesn't feel very good, but it's very important that we increase your heart rate. Celeste, can you give him 2 milligrams of morphine IV push?
There we go.
That's going to help you feel better. How are you
I
feeling
sure
now?
hope so.
Okay, where are we at, Celeste?
We're only getting intermittent capture at 40 milliamps right now.
Okay, increase it a little bit more.
Okie doke.
Ouch! Are you sure about this?
Yes, I'm sure. Celeste, give him another milligram of midazolam.
Okay.
That's going to help
Right.
you feel better. I know it's really scary to have something going on wrong with your heart, but we're doing everything we can to get you feeling
It
better.
hurts.
You'll be feeling better soon. We've got 100% capture at 50 milliamps. He's got good carotid pulses, and his blood pressure is 100/70 now.